Welcome to UO Today. I'm Paul Peppis, filling in for Barbara Altman. Our guest today is Linda Chapman, a nationally recognized expert in art therapy and play therapy with children who are victims of violence, child abuse, and medical trauma. She directs the Art Therapy Institute of the Redwoods in Northern California, a center for learning and therapy. Chapman was affiliated with the UC San Francisco School of Medicine for 25 years, where she held clinical, faculty, and research appointments. She created and for 10 years directed the San Francisco General Hospital Pediatric Play Therapy Program. She has authored and co-authored many peer-reviewed articles and chapters in professional journals and text. Chapman gave a talk titled The Neurobiology of Violence and Healing with Art Therapy on April 12, 2012, as the Oregon Humanities Center's 2011-2012 O'Fallon Lecturer in Art and American Culture. Her talk was part of the year-long Conflict series. Linda, thanks for speaking with us today.
You're welcome.
Can you define what art therapy is for those of us who are unfamiliar with the field?
Yes. The profession of art therapy is a combination of using your skills as an artist and your training in psychotherapy and psychology to offer a nonverbal method of expression for children, adults, anybody across the developmental spectrum as a method of healing. So the art therapist uses the actual art process itself as the healing method.
So how did the profession develop?
It developed out of a woman named Margaret Naumburg she was a psychiatrist who began noticing that her clients, her psychiatric clients, could express things in nonverbal ways through image that they weren't able to verbally express. So she began having people free associate with images. And then from there it developed back in the 40s, 50s with very few pioneers, and the first professional organization, the American Art Therapy Association, was established in 1970.
And you mentioned that the practitioners both have expertise in art making and art teaching and in psychiatry and psychology. Is that right?
Not necessarily teaching, but you do have to have a background in art. You don't have to be an exhibiting artist, but you do have to have a portfolio of work that shows that you have an affinity with the creative process and that you understand the creative process.
And what made you decide to pursue a career in art therapy?
Well, when I moved to San Francisco from where I grew up in Michigan, I began teaching preschoolers. And I became very fascinated with the preschoolers' drawings because the ones that had the most difficulty in preschool, their art and their drawings were very different, very chaotic, very fragmented. So I became very fascinated with the relationship between behavior and art. And I was reading a book on play therapy and I saw the words art therapy in the book. And having been an artist and wanting to combine the art and psychology, that was just the perfect words for me to read, and I went right back to school and redid my undergraduate degree in art and psychology and then went right into a graduate art therapy training program.
And is that sort of sequence, is that the typical sequence, or does it really vary depending on?
It's varied. A lot of people come in through the art. A lot of people come in through strictly an interest in psychology, but they have an art background. So there's many different mutations of art and psychology that bring people to the profession.
Could you tell us about the Art Therapy Institute of the Redwoods?
Yes, the Art Therapy Institute of the Redwoods has been established for 4 years, and it's a beautiful setting, very healing space that I have in Northern California. And I offer workshops and trainings for professionals in art therapy and play therapy there, and then I also have a clinical practice there where I see children and teens.
So you work exclusively now with children and teens, you don't?
Yes.
And I assume that there are plenty of art therapists that work with adults as well.
Exactly. There's people who work with adults in prisons, in mental health settings, in day treatment centers, and then across all the different opportunities for placement for teens and children.
So in
schools.
So in your practice, can you describe what a typical therapy session is like?
Yes, my practice is primarily severely disturbed violent teens at this time and younger children. So a typical art therapy session would involve them coming into the studio and me oftentimes having them start with something that's a fun, engaging activity. Oftentimes I use bilateral scribbling where they hold markers in two hands. And for them, it's fun and it's engaging and it's a no-fail exercise. But what I'm also doing in that process is stimulating the formulation of imagery and I'm also getting both sides of the brain activated at once. So we begin with something like that, usually a kinesthetic experience.
So just briefly describe when you say both sides of the brain. Remind
The
us
right
about the two
hemisphere
sides
and the
of
left
the brain
hemisphere.
and what's different about
Well, a
them.
lot of children have sensory motor delays and things that both sides of their brain aren't operating in sync with each other. And so what I do is a lot of times sensory motor, what I call sensory motor art, to help them get those sides of the brain in sync. And just for example, one teen that I've been seeing since November was completely failing in school, and now in April of this year, he's getting straight A's.
So which side of the brain is the side for the intellection?
That's the left
That's the
hemisphere,
left
is usually with logical, linear thinking, and the right hemisphere is much more the body-based affective processing.
So in this case, there seems to be some kind of disconnection or out of syncness, and
Exactly.
bringing them into sync improves both cognitive abilities.
Right, you
and
strengthen both sides of the brain and the connections between the two.
Interesting, interesting. So what types of art media do you have your patients use?
Well, I usually begin with fairly structured media, things like markers and pencils and collage material, because the more fluid the media gets, the more you access primary process or affective material. So for example, an art therapist would never randomly select materials. When I begin with very structured media because I want to see how do they handle the structured media and how do they handle what comes up with the structured media. And then gradually I introduce less structure to the point where maybe using paint or clay with water, things that are less controllable as they're able to handle it. But the properties of the media will either inhibit and contain primary process material, or it will facilitate greater expression.
So you often have a kind of trajectory where there's resistance that you need to minimize or overcome before the sort of more expressive stuff is happening?
Well, that, and you want to make sure the person doesn't get out more than they can handle. For example, if you go too far too fast, the client will shut down because it's too much and you've gone too far. So you want to titrate that expression. And with my violent teens, I want to work way more on containment than I do getting things up in the beginning of therapy. And then once they can regulate, then I'll work on getting to the more emotional material, because we've got to get that regulation in effect before we go and just dive into the material that would be overwhelming and dysregulating.
So when you do the interpretive aspect of your work, are you interpreting what they've actually created, or are you interpreting the way they're creating or the attitude they're taking in the creating process? I mean, are you looking at the images and saying, reading them in a certain sense?
Well, there's two parts to this. One part in the assessment phase, I usually have children do a few drawings for me if they're willing, and I watch for things in the drawings that I can pick up, such as neurological impairments. I might see signs, indicators of emotional abuse or maybe physical abuse. But I don't draw any conclusions from those things because it might just be my interpretation and not really what's going on. So I work from a hypothesis model where I might suspect those things, but then I will set up more interventions and things to see if whether or not that's true. That's pretty much in the assessment phase. But in the treatment phase, I do very little interpretation. My goal in that is to work more in what Alan Shore refers to as the intersubjective space that we meet in out here. And so I co-regulate with that client out in that intersubjective space. I don't rely on my cognition or my thoughts. I'm much more attuned to the patient's body, their affective responses, what's going on, and we co-regulate. So I don't really make interpretations. I'm much more interested in their own interpretations about their work than my projections.
Are there other art therapists who go more in the other direction?
There are.
I'm sure it's the same in all psychoanalysis.
It is, and I'll just say that in the art therapy profession, there's people who, like me, who work much more in the scientific medical model of art therapy, and then there's people who work more in the transpersonal approach, and there's a million shades of gray in between there. And so there's many different ways of applying the art therapy, and mine is much more the scientific medical model where I'm trying to reduce symptoms, I'm trying to change behaviors. So I have a very specific tasks that I'm not necessarily just exploring the person's, maybe their career problems or creativity problems. I mean, it's used in many, many different ways, but I have specific symptoms that I'm trying to reduce.
I know that, as you've said, you have particular expertise working with children and adolescents victimized by violence and abuse. Does art therapy have particular benefits for those patients, do you think? I mean, is it an especially effective way of helping those patients?
Definitely. I believe so, because one thing we know about the brain is that when someone's under stress, the neurochemistry in the brain is not operating the way it is in a normal human being. So a lot of these experiences are recorded in the right hemisphere in nonverbal modalities. So when you give a child who's been abused or a victim of violence a nonverbal modality to tell their story, they're able to draw from the unconscious, and many times they won't be able to tell me what they've drawn until they've drawn it. Then they can put words to the image, but they can't go the other way around, because what we would be asking them to do is to draw that material from the left hemisphere where it's not stored and there's no access to it. So that's why verbal therapy is very hard for people with trauma histories.
So art gives you a kind of special access to the unconscious.
To the unconscious, and then you also have the nonverbal modality. And when you take these internal feelings and you create a tangible, concrete object out here that contains it, for my children and teens, it's outside of them. So they're much better able to talk about something outside of them than something inside of them.
Interesting. You've mentioned a couple of times your particular orientation towards the medical or biological or neurobiological orientation. Would you say a little bit about how neurobiology informs your work?
Yes, I've been a student of Alan Shore for about 7 years, and it's informed my practice tremendously, and it's become way more effective in applying the neurobiology and the advances in the neurosciences in the clinical setting. And that's the new challenge for the new decade. We've learned all about the brain in the past 2 decades, and now the challenge is, how do we apply this? So the techniques and the things that I use with my clients are based on the neurobiology of attachment, on development, on early experiences that the child may have missed from an abusive parent or a drug-induced parent, where they didn't have the opportunity to build the experiences that scaffold how it is that we learn to think and process information. So a lot of what I do is go back and rework those neural systems and redo things that were deficits in early development in the art therapy.
So the art therapy actually helps to overcome trauma in some sense. I mean, it's a tool to help process the unprocessed traumatic event.
Because the core element of resolution is creating a narrative. In other words, a story with a beginning and a middle and end. So if you had a traumatic experience, you may have intrusive images, you may be triggered by smells, sights, perhaps a particular type of person, and those things just come in randomly, and those triggers, traumatic reminders, happen throughout life. And when we can organize that story into a story that is a narrative with a beginning, a middle and end, there's a neurochemical transformation that takes place that moves that processing to the higher structures. And it's the way you know it's done is because then the child has language about the event, which means it's been moved from implicit memory to explicit memory.
So does this final ability to verbalize, does the narrative have to be verbal, I guess is what I'm trying to ask. I mean,
it doesn't have to, but again, it's more integrated if the person can reflect that in language. But there's some children I worked with at San Francisco General Hospital who spoke Arabic, and I couldn't speak a word of their language, and the interpreters weren't arriving in time. And they would play out their trauma. I could see them playing it out over and over, which is what children do to master trauma, is through repetition of replaying and retelling. And I would see them do these replaying and retelling of the event, and the symptoms would abate. So even though I wasn't bringing it to consciousness, the act of the doing and the mastery still takes place.
But it's most often the case that the art therapy ultimately gets you to a place where the narrative is a verbal narrative. It's a linguistic.
Hopefully, yes.
And I would assume from what you've said in your discussion of working with traumatized children, that art therapy can also be helpful for veterans with post-traumatic stress disorder.
Yes.
Yes. And that, I assume there are people that do that as well.
Oh, yes. There's a big program at Walter Reed Hospital in Washington where there's many art therapists working very successfully with veterans. There's a lot in the news about art therapy with veterans currently.
Do you find that patients are more amenable to art therapy because it's less freighted with cultural associations than psychotherapy or psychoanalysis?
Yes, that's true, but also with many of the violent teens that I see, it's kind of the last resort. They won't go to other therapies, and they'll say, well, you could go to this art therapy where it's different, you don't have to talk. And so that's sometimes what gets my teens in, is they're mandated by the court or they have to go. And so they'll go to that because they think they won't have to talk about their families and things that they typically don't want to do.
So that's really one of the great advantages of art therapy.
Definitely.
It is a way of beginning the process non-verbally.
Right.
Interesting.
Yeah, some of my teens don't even verbally talk to me when they come in. They make noises. Or it may take them an hour and a half to even get out of the car. So my pacing is much like how you would meet an infant. I go with their pace, I go with their agenda, I do everything based on their neurobiological needs. And that's what gets them to be willing to, because I'm starting very early in development. I'm not expecting them to walk in the door and be their age that they are.
So you can treat a patient 30, 50, 100 times in some cases because you have to go so slowly in certain cases?
Well, optimally, you would like a couple years of therapy. A lot of my kids get bounced from the system because they turn 18, so then there's no longer any funding for their treatment. But optimally, most of the children that I work with for a couple years, they pretty much are out of that cycle.
I assume that sometimes you encounter in your patients' artwork imagery that's fairly disturbing, upsetting. How do you deal with that? I mean, as a personal matter. I mean, is there a... I'm sure that part of the training is to prepare yourself for that kind of thing.
Well, you know, it's that's a difficult question because you can't separate yourself from the suffering in some ways, but then in other ways you do learn how to create a balance in your life so that you are not only doing one type of work or you're only doing that. I have a nice support system. I live in a beautiful area. I garden. I have teaching duties. I have writing. I'm writing a book. So I balance it with other things. I don't do 40 hours a week of that. When I was at San Francisco General, I got very burnt out and had to leave because of burnout. So I'm very conscious now of being aware of monitoring myself in the process.
I've read a little bit about this notion of vicarious traumatization, which happens to people that are working in really intense clinical.
Yes.
From what you've said, I assume that you've had experience with
I
that.
have.
And can you say a little bit more about how clinicians cope with that kind of problem?
Well, there's adaptive and there's maladaptive ways of coping. I'm doing some Healing the Healer workshop at Lane Community College tomorrow.
Interesting.
And one of the things that often comes up in that workshop is people's ways of coping. And, you know, some people are unfortunately use drugs and alcohol as a way of coping, and they use other maladaptive things. But most people try to really do yoga, exercise, healthy eating, pay attention to your sleep, do these things that keep you in a healthy sense. But you have to be constantly aware of that, and you have to check yourself for symptoms. You have to be completely aware. That's the biggest thing. The biggest thing is the awareness
and
that it exists.
I assume that it can happen that if you're a clinician, a therapist, and you're not dealing with this could have a significantly negative impact on your effectiveness with patients as well.
Oh yes, and there are in the literature cases where therapists have acted out and done things that are inappropriate because of being stressed and overwhelmed and not feeling valued, and so it can become a liability for the institution if they're not aware of this and they aren't aware that people need to be aware of their symptoms and monitor these things and take a break, and maybe go into a different kind of work for a couple of years and work with a different population and then maybe go back to doing trauma work. But you have to balance the practice.
So can you say a little bit more about this this workshop that you're doing at Lane tomorrow?
Yes, well what it is it's designed as a healing method for therapists. So we don't tell trauma stories and when people don't get more traumatized. What they do is they learn some very concrete information about symptoms and symptom management, but we also do I think there's three art experiential sessions that really are designed to heal. So by the time they come away from that, they have reset the thermostat back to a place of balance, hopefully, and then they have new knowledge that will help them stay more aware and remain in a state of balance. Because sometimes, like you look at some CPS workers who've been doing this for 30, 40 years and they're so overworked that they don't even pay attention, and then all of a sudden they just have to quit or they collapse because it's just so overwhelming over time.
So you use art therapy also to help therapists?
Yes, definitely.
And is it common for art therapists to use art therapy for themselves as well?
Yes, very much so. When I worked at the General, sometimes I would come home after a bad day and I would just paint something huge, and I would go look at it the next morning and I was looking down the barrel of a gun, or I had painted exactly what I was dealing with that day, but didn't even realize it until the next day when I looked at it. So it's a way to keep that energy moving, keep the visual stuff moving through you, because if it gets stuck, that's what I call dis-ease. It can make you sick and affect your immune system.
Interesting. So you've just talked a little bit about your own experiences making art therapeutically. Do you also make art for non-therapeutic reasons?
Yes, I love to paint and draw and almost any kind of, I love cooking and gardening and creating things. I wish I had more time with my book and my practice and everything else. It gets put on the back burner, as it does for a lot of art therapists who kind of mourn that loss. And so we all try to get back to it. Some are better at it than others, but I imagine I'll get to that later in life again, is the way I kind of conceptualize it.
I know that, I read a little bit about the history of art therapy, and is it now firmly established and really credible within the medical profession, or is it still viewed as a kind of less legitimate or marginal field?
Well, that's a great question, because in mental health, where you would think that art therapy would be more widely accepted, it's much more of a battle. But in medicine, I find that people are much more open to art therapy programs, art therapy placed in the medical setting. And I think it might have something to do with physicians and surgeons are open to new procedures, new ways of doing things. So they're more welcoming. I can remember times at the General where there were children who couldn't be anesthetized for a surgical procedure. And I would go in there with my guided imagery, my little boombox, and these doctors would say, okay, but I don't think this is going to work. But they would let me try it. And then, of course, it was successful. And so they were just amazed that I could do this and put the child into an altered state just with imagery.
Interesting.
And they could do the procedure and the child wouldn't even be, and they'd be amazed that that could happen. So I think that they're open to newer things, and so it's a little more widely accepted. And also in the mental health profession, the licensed professional therapists and the social workers, they kind of claim that as their territory, and so art therapy's always had to try to prove itself in that domain. But it's the 4th hottest job in the U.S. now. A lot of interest in art therapy programs. There's many PhD programs in art therapy, and the art therapy programs that I know of in the U.S. are just growing in leaps and bounds.
Interesting.
So it's the new frontier as we move to a more mind-body approach to medicine.
Interesting.
It's going to be revisited.
Can you tell us something about the relations of art therapy to so-called outsider art?
Well, it's not my area of expertise, but I know that there are a lot of art therapists who work in that realm with outsider art and using art, but it's just not an area of my knowledge or expertise.
Okay. Are there any particular developments occurring these days in the field of art therapy that are especially notable or groundbreaking?
Well, there's a lot of great things happening, but the problem right now that we need so desperately is outcome research. There's very little really good randomized controlled studies to show the effectiveness of art therapy. There's a lot of case studies, and there's a lot of studies that are not randomized, and so those don't really count very much. So we need to really put an effort on research, and that's where the field is really looking right now. Is I'm trying to come up with a science-based explanation of art therapy, but also we need that outcome research. So that's the focus now, and
so
veterans.
Who would do this outcome research? Would art therapists do it, or would you need
in collaboration with other professionals? Usually these magnitude of studies involve different disciplines contributing to it. When I did my randomized controlled study of an intervention that I developed for hospitalized children, there was one person looking at the incidence of PTSD in hospitalized children. There was another person looking at whether the parents could effectively rate the child's symptoms. So you get other people involved in a collaborative effort, and it's much better, and then there's more opportunities for funding.
Is there resistance to doing this kind of work? Doing these kind of studies? Or is it just an indicator
Some
of
art therapists have a hard time qualifying art therapy because they think that you can't qualify art. But again, outcome research doesn't look at anything to do with the art. It looks at outcomes. Can you reduce the symptoms? Can you change the behaviors? Can you change something in the way the person is, relating or living? So the resistance is kind of, I think, fading away as people recognize more and more that we're looking at outcomes that can really substantiate the effectiveness.
My last question is about, you mentioned you're advocating for a scientific approach. What's the alternative to a scientific approach?
Well, the more we can give a scientific-based explanation for how art therapy works, I think the more credible it becomes. For example, music therapy came up with a science-based explanation of how their profession works, which is very similar, but they had a 44% increase in referrals once they were able to explain it scientifically. So I think that the world of science and medicine, the more we can articulate exactly what we're doing and why it's working neurologically, that will help us as well.
That's a perfect way to end for us. Linda,
thank you.
Sorry to say we're out of time, but it's been great speaking with you.
Thank you. It was a pleasure, and I enjoyed meeting you. Thank you.
We've been speaking with Linda Chapman, a nationally recognized expert in art therapy and play therapy with children who are victims of violence, child abuse, and medical trauma. She directs the Art Therapy Institute of the Redwoods in Northern California, a center for learning and therapy. Chapman gave a talk titled The Neurobiology of Violence and Healing with Art Therapy on April 12, 2012, as the Oregon Humanities Center 2011-2012 O'Fallon Lecturer in Art and American Culture. Thanks very much for watching.